welcome you to this wonderful lecture. I want to implore you to please find a suitable place for yourself, because any moment from now, the academic procession will file in. Any moment from now, the academic procession will file in. Please make yourself seated comfortably. It's now time for the academic procession. Now, please, may we now rise for the academic procession.
strategic partnerships, registrar, the bursar, university librarian, provost of the College of Medicine, provost of the postgraduate college, the dean of the Faculty of Basic Clinical Sciences, deans of other faculties and of students, directors of institutes and centers, heads of departments, distinguished guests, ladies and gentlemen. The 565th University of Ibadan Inaugural Lecture will be delivered this evening by Professor John Ayodele Olaniyi of the Department of Haematology on behalf of the Faculty of Basic Clinical Sciences in the College of Medicine. Professor John Ayodele Olaniyi was born on 15 April 1960 in Kumasi, Ghana, to the family of late Mr. Nathaniel Olaniyi and late Madame Susanna Titilade Olaniyi of Alalas Compound, Oyo, in the Ojuoti local government area of Osun State. Although he started his nursery school education in Ghana, he returned to Nigeria shortly after to attend St. Paul's Anglican Primary School, Oyo, because Nigerians were asked to leave Ghana at that time. He obtained a modern school certificate before proceeding to Class 2 at Faculty Comprehensive High School, Osogbo, where he obtained the West African School Certificate with distinctions in 1980. He gained admission to Obafemi Awolowo University in the same year to study medicine and surgery. He graduated in 1987 as a holder of BSc Health Sciences in 1984 and Bachelors of Medicine, Bachelors of Surgery in 1987. He completed his housemanship with the Oyo State Hospital Management Board in 1988 and proceeded for the mandatory National Youth Service Corps program, NYC, in Plateau State in 1989. He worked with the Oyo State Hospitals Management Board as a medical officer and then joined the services of the University College Hospital Ibadan for residency training in Haematology, laboratory medicine in June 1991. He became a member of the National Postgraduate Medical College in 1994 and a fellow of the West African College of Physicians in April 1998. He was first appointed as Lecturer 1 and Consultant Hematologist at the Ladoke Akintola University of Technology of Omosho in June 1998. Professor Olaniyi joined the services of the University of Ibadan in February the year 2000 as Lecturer Grade 1 and Consultant Hematologist in June 2001. He was promoted to the grade of Senior Lecturer in 2003. He thereafter obtained a qualification of Masters of Science in Chemical Pathology of the University of Ibadan in 2007. He was promoted to the grade of Reader in 2013 and Professor in 2016. He has served and is still serving the University of Ibadan in various capacities. He was acting head of department from August 2017 to July 2019. He is the current head of department from August 2023 to date. He was the chairman of the Curriculum Committee and Appointments and Promotion Panel representing the Faculty of Basic Medical Sciences between 2021 and 2022. He is the current Appointments and Promotion Representative of the Faculty of Basic Clinical Sciences and the College of Medicine. He was part of the organizing committee for the 7th Ibadan Conference on Biomedical Research held in September of 2021. He has received several University of Ibadan Senate research grants, which include the Individual Research Grant 2006 and 2007, and Group Research Grant in 2010. Outside the University of Ibadan, he was a visiting scholar to the University of Chicago in 2010 to understudy phenotyping through a joint UICC Global Health Scholarship. Professor J. Olaniyi, first person for the West African College of Physicians, serving as a trainer at the regular update courses as well as an examiner at the respective fellowship examinations. He has been an examiner of the West African College of Physicians in laboratory medicine since 2003 till date. He is currently a host examiner in hematology. He was the local organizing committee chairman LOC for the recently concluded 48th Nigerian Society of Hematology and Blood Transfusion, held between 28th and 30th of August 2024. Professor Olaniyi has served as examiner for the MBBS Part 2 professional examinations in some Nigerian universities. First, the College of Medical Science, University of Maiduguri, Olabisi Onabanjo University, College of Health Sciences, Agoiwe, and Osun State University, College of Health Sciences, Osogbo. He has also served as postgraduate MSc external examiner to Obafemi Awolowo University, Ile-Ife. He is a member of several learned societies, among which are the Medical and Dental Association of Nigeria, 1988, West African Postgraduate Medical College, Nigeria, 1998, Nigerian Society of Haematology and Blood Transfusion, 1998, African Society of Blood Transfusion, 2001, American Society of Clinical Oncology, 2011, and the American Society of Hematology, 2012. As a consultant hematologist, he is fully involved in the management of patients with various hematological disorders. He is a co-trainer of many postgraduate students and residents in hematology through the regular world round, clinical teachings, seminar presentations, and close supervision of their research. His research interest is in hematology, oncology, particularly leukemias, lymphomas, and multiple myelomas. He was a winner of the Global Health Award to understudy immunophenotyping at the University of Chicago in the year 2010. This was facilitated by Professor Fumilayo Olopade of the University of Chicago. Professor Olaniyi has served and is still serving as reviewer to many journals, some of which include the Medical Journal Biomedical Services, Hong Kong in China, African Journal of Medicine and Medical Sciences, Nigerian Journal of Postgraduate Medicine, Annals of Ibadan Postgraduate Medicine, Ethics Committee of the University of Ibadan and the University College Hospital Ibadan, African Journal of Biomedical Research and Annals of African Medicine. He is a member of the editorial board of the African Journal of Medicine and the Medical Sciences. Professor Olaniyi has over 80 publications in both national and international journals, which are available in research and scientific databases. He has attended several conferences and training workshops, both locally and internationally. Professor Olaniyi is married to Dr. Adenike Olaitan Olaniyi, the current principal of the School of Medicine, University College Hospital, Ibadan, and the marriage is blessed with two lovely daughters. Distinguished ladies and gentlemen, I now invite Professor John Ayodele Olaniyi to present his lecture, which is titled Blood Cells Eccentricity, Looking Out and Looking After the Afflicted. Professor Olaniyi.
Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academics, Deputy Vice Chancellor Research, Innovation and Strategic Partnership, Registrar, Librarian, Provost of the College of Medicine and the Postgraduate College, Dean of the Faculty of Basic Clinical Sciences, Dean of Faculties and of Students, distinguished ladies and gentlemen. I thank the Almighty God for keeping and leading me to this point. It is a special day that the Lord has made. I'm highly delighted to stand before you today to give this inaugural lecture on behalf of the fledgling Faculty of Basic Clinical Sciences. This is the first inaugural lecture to be delivered from Faculty of Basic Clinical Sciences. I'm grateful to the Dean for nominating me for this prize, the 565th Inaugural Lecture of our University of Ibadan. This is the fourth inaugural lecture from the Department of Haematology. Professor E.M.S.N. delivered the first inaugural lecture in the department in 1989 and was titled, "May the Blood Continue to Flow in Our Body." The second inaugural lecture was delivered by Professor Ayodele Olaniyi in 2005 and was titled, "The Streams of Life." The third lecture was delivered by Professor Olaye in 2011 and was titled, "Bleed Not My Son." This inaugural lecture is titled, "Blood Cells Eccentricity, Looking Out and Looking After the Afflicted." My journey to hematology. Post-NYSC in 1989, I was deployed as a medical officer. I was employed as a medical officer at Ring Road State Hospital, Ibadan. I was in medicine department under two consultant physicians, namely Dr. Aishekoni of blessed memory and Dr. Tunde Oduson. For inexplicable reasons, I was deployed to Sickle Cell Clinic within the first 2 months. I had to report to work under supervision of Dr. Titi Ipadeola of blessed memory, a consultant hematologist. I developed interest in the activities of the clinic and got excited in the whole activity of taking care of sickle cell disease patients, both in crisis and in steady state. He performed many bone marrow aspirations and reviewed the blood film of any leukemias with me. This got me excited and interested in the discipline. Coincidentally, Dr. Laura Adeshina, a co-tenant who had just joined residency training in the Department of Pathology, approached me and asked whether I would be interested in residency training in hematology because the department desperately needs more resident doctors. I followed him to that department the following day and met the HOD, then Dr. B.A. Ogusanwo. He cheerfully welcomed me and wanted me to even start work, if possible, immediately. I eventually started work 1st of June 1991. Hematology as a specialty. Hematology is the specialty responsible for the diagnosis and management of a wide range of benign and malignant disorders of red cells, white cells, platelets, and also of coagulation factors. Hematology is both clinical, bedside, and also laboratory medical sciences. Hematology subspecialties are hemostasis, hemoglobinopathy, hemato-oncology, blood transfusion medicine, general hematology, bone marrow, stem cell transplant, blood cell types and development of blood cells. Blood consists of cellular and non-cellular components, providing nutrients and keeping every organ and tissue optimally functional. Therefore, we know that blood is life. Blood cellular components consist of white cells, red cells, and platelets. What are the functions of these cellular components? Erythrocytes, for example, contain just hemoglobin, which transports oxygen from the lungs to tissues and bring back carbon dioxide from tissues to the lung for respiration. Leukocytes are subdivided into two, the granulocyte and the lymphocyte. They all protect the body from infections, foreign antigens, and cancer cells. Platelets play a very crucial role in balancing out of maintaining blood in fluid state, preventing bleeding, and at the same time, preventing clot or thrombus formation. And that is what we refer to as hemostasis. Blood cells eccentricity. Mr. Vice Chancellor, sir. In the next few paragraphs, I'll be discussing and relating hemopoiesis and the respective blood cells eccentricity, that is, the relevant physiology and pathology of erythrocytes, leukocytes, and thrombocytes. I will also provide a summary of my expertise in this prime specialty of medicine. What is eccentricity? Eccentricity denotes aberrant, abnormal, anomalous, irregular, unconventional, uncommon, or odd. Eccentric blood cells emerge when there is a disruption in the dedicatedly controlled process of sequential development of precursor cells, which are like seeds from highly primitive cells called the stem cells, leading to the production of the red cells, white cells, and platelets in the bone marrow. And the bone marrow is analogous to the soil. Abnormality of either the soil or the seed or both may be involved in the development of eccentric cells. Red cell eccentricity. The red cell eccentricity may manifest as anemia. Anemia may be due to inherited or acquired conditions. Examples of inherited conditions are sickle cell disease, thalassemia, and many inherited membrane disorders. While acquired disorders result from many causes, part of which is iron deficiency, vitamin B12 deficiency, and folate deficiencies, among other causes of anemia. Polycythemia, on the contrary, which refers to excessive production of red cells, can equally occur, and this can be due to secondary causes that are identifiable in the body system. The other part is primary, which is malignant. White blood cells eccentricity. Leukocytosis denotes elevation of white blood cells in the peripheral circulation. This can be due to many causes, part of which is bacterial infection and any other thing that can trigger inflammation. Leukopenia, on the other side, is a reduction in the white cell count, predisposing the individual to immunosuppression, heightened susceptibility to infections. Common causes include aplastic anemia, HIV infection, typhoid fever, and many other causes. Malignant white cell disorders are legion. It includes leukemias, lymphomas, multiple myeloma, myeloproliferative neoplasms. The lymphomas are classified into two: Hodgkin's lymphoma, which is typically characterized by the presence of an abnormal eccentric cell called the Ristimba cells, whereas the non-Hodgkin lymphomas are very heterogeneous. Platelet eccentricity. Thrombocytosis denotes elevation of platelet count. Thrombocytopenia, on the other hand, denotes reduction in the platelet count, resulting in the increased tendency for easy bruising and hemorrhagic diastasis. Abnormal platelet function can equally occur, and this is what we refer to thrombocytopathy. How do we then look out for eccentric cells? There are many tests that we do in looking out for eccentric cells, but the most basic and most fundamental is what we call complete blood count or full blood count. Every hospitalized patient will have this test done routinely. Also, all healthy individuals must have this test done at least twice a year as routine medical test, because abnormality of certain parameters of the test may be diagnostic or, in fact, predictive of insidious diseases. There are some incidental diseases that we discover by doing this full blood count on some people. Polycythemia that I mentioned can be discovered in that manner. Likewise, chronic lymphocytic leukemia and chronic myelocytic leukemia. Peripheral blood film is another test we do, and these affords us the opportunity to view these eccentric cells under the microscope. Various eccentric cells are seen based on the nature of the hematological disorders. For example, irreversible sickle cells are seen in sickle cell disease. Others are bone marrow aspiration and biopsy. This also allows us to view these eccentric cells under the microscope and ability to view the abnormal cells from the source, the bone marrow. Cytochemical staining is another test we do. This stains each of the eccentric cells distinctly, and we are able to recognize them by the type of stain they take up. Histology is what we do for tissue malignancies, solid tumors. We send the tissue to histopathology, they look at it under the microscope and give us a report. This is relevant in the management of lymphomas in my department. Immunophenotyping is a very crucial and essential test that we do. Immunophenotyping employs the use of monoclonal antibody to tag and identify each cell by the type of CD markers they carry. Each cell has its own unique markers that can be typed using monoclonal antibodies. There are two ways we go about it, either through flow cytometry immunophenotyping or the use of immunohistochemistry. Other tests that we do are genetic and molecular tests. These genetic and molecular tests are very important in helping us to identify the basic and fundamental genetic abnormality that are behind the development of the eccentric cells. Cytogenetic analysis is one, fluorescent in situ hybridization is another, molecular genetic analysis, whole genome scanning, and microarray and analysis of gene expression are the tests that we do. The next picture is showing me in a laboratory, immunophenotyping laboratory in the University of Chicago when I was there in 2010. Looking after the afflicted. Looking after the afflicted may require non-complex measures, but complicated regimens may be the only option in some instances. While severe anemia in a 4-year-old child with malaria will not require more than adequate treatment with anti-malaria drugs, and one-off blood transfusion, anemia resulting from blood cancers will require institution of complex protocols, and success at times may be elusive. Treatment modalities for the restoration of eccentric cells to normal may include supportive and definitive. Supportive therapy usually require infusion of red cell concentrates and then platelet concentrates as indicated. Also, administration of white cell stimulating agents like granulocyte colony stimulating factors may be indicated. Commonly, intravenous fluid is usually copiously given, and treatment of infections are usually handled using appropriate agents. Definitive care include the following: chemotherapy, and this is the commonest modality usually employed. Immunotherapy is another mode of therapy. Stem cell therapy is another mode of therapy, and CAR T-cell therapy, which means chimeric antigen receptor T-cell therapy. This is like engineering the patient's immune cells to treat their cancers. It's like giving the patients a living customized drug. The chimeric antigen receptors recognize and bind the specific proteins or antigens on the surfaces of the cancer cells and kill them. This picture illustrates the modality of employing CAR T-cell therapy. My contributions to science. My academic journey into hematology began with my work with my teacher and mentor, Professor Yetunde Akenova, along with Professor R.A. Bakare. We evaluated the bacterial causes of osteomyelitis among patients with sickle cell anemia. Of the 25 patients, blood culture and/or direct wound swab revealed the following: Klebsiella species in 45% of the patients, Staph aureus in 20%, Salmonella species in 8%, Streptococcus pyogenes in 4%. This study established a change in pattern of bacterial causes of osteomyelitis in sickle cell disease patients from previously known Salmonella species to Klebsiella species as the commonest cause of osteomyelitis. Akenova et al. In 1995. Subsequently, we assessed the hematological parameters, including bone marrow changes in 62 pre-treatment sputum smear AFB positive pulmonary tuberculosis patients towards submitting the dissertation to West African College of Physicians. Professor Y. Akenova was my supervisor. I'm glad to note that 2 publications were extracted from this research work. Olaniyi J.A., 2003. We reported the following prevalence in the patient. Anemia was found in 93.6% of the patients, leukocytosis in 22.3%, neutrophilia in 45.2%, lymphopenia in 4.8%, and thrombocytopenia in 8% of the patients. None of the patients had leukopenia, and only 8.4% had lymphocytosis. Olaniyi et al. 2003. Also, the cytology of the bone marrow and the differentials were done, and our findings include depressed erythroid activity in 69%, micronomoblastic changes in 18%, megaloblastic changes in 16.6%, increased myeloid activity in 65%, normal-looking plasma cells about 5% in 17.7%, and eosinophilic precursors about 5% also was found in 12.9%. None of the marrow smears showed granuloma formation or caseation necrosis. The bone marrow culture yielded no growth of Mycobacterium tuberculosis, while stainable iron in the bone marrow was found to be low or negative in 88.8% of the patients. Olaniyi and Akenova, 2003. Palliative radiotherapy. A review of the effect of palliative radiotherapy in the management of multiple myeloma patients on standard chemotherapy in UCH Ibadan was done. We observed reduction in total relief of pain, also observed healing of pathological fractures, and improvement in performance status and the quality of life of these patients. So it was concluded that early identification and appropriate irradiation of bony myeloma tumors deposit, in conjunction with standard chemotherapy, reduced morbidity, improved quality of life, and survival of these patients. Elumelu et al., 2001. We also did a work on therapy-related AML. We reported a case of a 52-year-old man diagnosed of Hodgkin's lymphoma, who between 1983 and 1985 received 4 cycles of combination chemotherapy. He later developed acute myeloid leukemia 8 years after cure. This study reinforces the need for thorough counseling of patients on the possibility of development of secondary malignancies as a late complication of cytotoxic drug therapy. Shokubi et al., 2005. Mr. Vice Chancellor, sir, I can say without any equivocation the management of sickle cell disease attracted me or even lured me into the field of hematology. Consequently, I do not need further justification for investing substantial energy, quality time, and intellect in the study and clinical management of sickle cell disease patients. But I hasten to indicate that I have not marginalized other aspects of blood cells eccentricity as well. Sickle cell disease. Sickle cell disease is an autosomal recessive inherited disorder affecting structure of normal hemoglobin, that is hemoglobin A. More than 300,000 infants are born annually worldwide with sickle cell disease. The vast majority, over about 75%, of which occurs in sub-Saharan Africa. At a national level, the burden of sickle cell disease is highest in Nigeria, and the conservative sickle cell birth prevalence is 2%. Due to impact of sickle cell disease and sickle cell trait on the socioeconomic status of Nigeria, quality of life on the patients, and the burden on the family, the diagnosis and management of patients with sickle cell disease remain paramount. Thus, this forms the basis of the following studies we carried out. Hemotype SC, we evaluated the overall accuracy, specificity, and sensitivity of hemotype SC in identifying hemoglobin AA, hemoglobin AS, hemoglobin AC, hemoglobin SS, hemoglobin SC, and hemoglobin CC phenotypes across multiple Nigerian primary health centers in real-life field setting in order to scope the potential for the large-scale use throughout Nigeria and also other sub-Saharan African countries. Overall, hemotype FC test identified 834 hemoglobin AA, constituting 74.3%, 257 hemoglobin AS, constituting 22.9%, and 16 hemoglobin SS, constituting 1.4%, and 14 hemoglobin AC constitute 1.2%. This study provided the first national study of point-of-care device in an African country. Also, our SparkNet multi-center survey of acceptability of newborn screening for sickle cell disease in Nigeria, in which Professor B.J. Brown and my humble self were the site leads for University College Hospital Ibadan, evaluated 1,301 respondents and revealed that 86.1% of these respondents supported newborn screening, Nodu et al. 2018. We observed that the most acceptable form of sickle cell screening was the one done before marriage, constituting 95.7%, while the least acceptable was prenatal diagnosis, constituting 73.8%. Sickle scan. The performance characteristics of novel point-of-care sickle testing device, sickle scan, was compared with cellulose-assisted electrophoresis and high-performance liquid chromatography, Nwegu et al. 2017. The efficiency of the sickle scan test was observed to be 98.2% for hemoglobin AA and sickle cell trait and sickle cell disease, that is hemoglobin SS and hemoglobin SC, and 96.5% for sickle cell trait, hemoglobin AS, and also for hemoglobin AC. Similarly, overall test efficiency of cellulose-assisted electrophoresis was 100%, 93.0%, and 94.7% for sickle cell disease, sickle cell trait, and hemoglobin AA. And hemoglobin AA and hemoglobin AA phenotype, respectively. Findings from this study show that sickle cell scan is a viable screening tool that can easily be applied in community-based screening for easy diagnosis of sickle cell disease with little expertise and also at a low cost. Nwegu et al. 2017. Fetal hemoglobin. Sickle cell anemia is known to have considerable clinical expression, ranging from death in early childhood to normal lifespan with few complications. These variations are due to the influence of genetic modifiers, like coexistence of alpha thalassemia and other factors such as hemoglobin F. Interestingly, the elevated hemoglobin F level, among other biological and environmental factors, has been shown to be associated with mild clinical cause of sickle cell anemia and decreased mortality. In our study on the hemoglobin S status of patients with sickle cell anemia in steady state, Olaniyi et al. 2010, we observed that hereditary persistence of hemoglobin F was rare among sickle cell anemia patients attending our medical outpatient clinic at the University College Hospital, since only 10.6% had hemoglobin F between 10.1 and 16%. However, the study observed that substantial proportion, 68.2% of sickle cell anemia patients, require treatment with hydroxyurea to stimulate hemoglobin F production, especially those with hemoglobin F percentage that is less than 2, and some with hemoglobin F percentage between 2.1% and 10%. We also explored the complications in sickle cell disease, hepatosplenomegaly. Sickle cell disease is associated with myriads of complications, Olaniyi Alagbe 2015. In our study, we observed the following. Splenomegaly was present in 21% of the patients with mean splenic size of 8.7 cm. Hepatomegaly was, however, present in 59% of the patients with mean hepatic size of 7.6 cm. Our study also confirmed the assertion that females hemoglobin S have higher survival advantage than the male sickle cell anemia patients. Musculoskeletal complications of sickle cell disease. Musculoskeletal complications of sickle cell disease remain the commonest clinical manifestation of sickle cell disease. In 2012, we reported a devastating case of multiple bone and joint complications in a 20-year Nigerian with sickle cell disease, Olaniyi et al. 2012, and other complications by Olaniyi Alagbe in 2015. The need for multidisciplinary approach in the management of sickle cell disease patients was exemplified by these studies. Sickle cell disease and pulmonary hypertension. One of the complications of sickle cell disease is pulmonary hypertension. When the tricuspid regurgitant jet velocity is greater than 2.5 meters per second. In our study, 12.2% of the population fulfill this criterion. We also observed that larger ventricular dimensions and volumes, higher stroke volume, and increased left ventricular mass, indexed by body surface area, were associated with pulmonary hypertension. Also, multivariate analysis showed that male sex and lowered Park cell volume were independent predictors of pulmonary hypertension in patients with sickle cell disease, Ayodele et al. 2019. Chronic inflammation in sickle cell disease. Chronic inflammation is an established feature in patients with sickle cell anemia, Acknowledgements et al. In 2018. In our study, we showed that pro-inflammatory cytokines, tumor necrosis factor, alpha, interleukin 8, and endothelin 1 were elevated in sickle cell anemia patients, especially in those with severe total summary pain score. Alagbe et al. In 2018. We have also shown that neutrophil lymphocyte ratio is elevated in sickle cell anemia patients and had positive correlation with platelet lymphocyte ratio in sickle cell anemia, both in steady state and in vaso-occlusive crisis. Alagbe and Olaniyi et al. 2019. Earlier, we had showed that C-reactive protein has a superior diagnostic performance for vaso-occlusive crisis in sickle cell anemia patients than stress biomarkers, cortisol and copeptin. Serum levels of cortisol and copeptin and their ratio could differentiate severe sickle cell anemia from mild or moderate sickle cell anemia. Acknowledgements et al. 2013. We therefore concluded that immunotherapeutic interventions Targeting these inflammatory peptides could help ameliorate or forestall bone pain crises in sickle cell anemia patients. Neoplasms in sickle cell disease. This is a double eccentricity. Several neoplasms, including hematological malignancies, have been reported for patients with sickle cell anemia. IgA myeloma was reported in a newly diagnosed sickle cell anemia patient in 2018 by Olaniyi and Adebola Shonde in 2018. We also have another sickle cell disease patient who developed acute myeloid leukemia. Our study underscores the relevance of high index of suspicion and prompt review of peripheral blood film of sickle cell anemia patients, particularly when patients present with unremitting symptoms associated with anemia and fever. Aworanti et al. 2020. These case reports indicated that severe anemia, sickle cell anemia patients are not exempted from developing cancer, and the diagnosis of the two conditions usually overwhelms the social and economic support of patients and caregivers. Concluding remarks and recommendations. Mr. Vice Chancellor, sir, ladies and gentlemen, I have detailed how blood cells vary in number and in quality, in shape, in size, and in structure, even in functional ability. I suppose you will agree that a minor change can cause a major disorder. I have also demonstrated that events that lead to the creation of these unusual cells can be hereditary or acquired, but they are usually a combination of the two. Newborn screening and genetic counseling for sickle cell disease are effective for informed marriage decisions. However, many marriages lack testing, and compounded by the fact that non-accredited laboratories often give incorrect results. We therefore recommend that point-of-care testing with high sensitivity and specificity, like hemotype SC, should be available in healthcare centers in all local governments for easy screening of hemoglobin types. I recently saw a publication titled, "No laboratory in Nigeria can diagnose my condition," quote and unquote. This lamentation comes from a sickle cell disease patient of type hemoglobin S beta thalassemia, diagnosed in the United Kingdom. This diagnosis cannot be made just by using cellulose acetate hemoglobin electrophoresis, which is the standard hemoglobin phenotyping test available in most of our Nigerian hospitals and laboratories. This incident highlights the critical need to expand our diagnostic technology across the country. Our hospitals and university research laboratories should explore public-private partnership to ensure sustainable equipment and facility, such as high-performance lipid chromatography, isoelectric focusing machine, as well as polymerase chain reaction machine for hemoglobinopathy diagnosis and confirmation. The practice of precision and personalized medicine is far-fetched from us. For example, acute myeloid leukemia, which is renowned for its variable biology and prognosis, is nevertheless being treated as if it were a single disease. To enhance the outcomes of our patients with blood cancers, there is urgent need, now more than ever, for significant investment in diagnostic capability of our laboratories and to making better treatment options available and affordable to our patients. One key facility that must be available in all tertiary health facilities for accurate diagnosis of blood cancers, that is hematological malignancies, in Nigeria is flow cytometric immunophenotyping laboratory. It will be a severe error to conclude this lecture without noting the shortage of labor in my field. National and sub-national governments, as well as relevant Nigerian women managers, must rise to this occasion to immediately reverse the so-called Japa syndrome and turn the tide towards Japada. The threat is serious and is existential, especially as our population grows. We also need to make hematology more appealing and attractive to younger colleagues so that they can specialize in it. Today, I can boldly say, so far so good. To God be all the glory. Acknowledgements. I want to begin by expressing my sincere gratitude to the Almighty God, the Alpha and the Omega. Mr. Vice Chancellor, sir, it is with a joyful heart that I thank my beloved late parents, Mr. Ayodele Olaniyi and Mrs. Susanna Titilade Olaniyi ni Ojo, for their labor on us and for making us to have quality education that they didn't have. I'm grateful to my late Mr. Amos and Mrs. Rebecca Adeyema. This is the family that nurtured me when I was in secondary school. I thank my uncle, Mr. Segun Ojo, who was the brain boss behind my vehicle of academic progress. He happened to be a born mentor. I appreciate my late uncle, Reverend Canon Dr. P.F. Ojo, and Mrs. Ojo for his support and care. I appreciate my mentor, Dr. Titi Padiola, who inspired me to think of becoming a hematologist. I thank all my teachers and mentors in hematology, Professor Y.A. Akenova and Professor Wura Olashokunbi, Professor B.A. Ogunsanwo and Dr. Mausi Okunade, who made a hematologist out of me. I greatly acknowledge my colleagues in the Department of Hematology for their hard work and cooperation in uplifting the image of our department. I thank Professor Taiwo Kotila, Dr. Foluke Fashola, Dr. Titi Akigbola, Dr. Peter Ogundeji, and Dr. Oladapo Aworanti, Dr. Chima Akunwanta. I also appreciate all the current resident doctors, even though there are no more than 3 in the department now. There is no way I can forget Mr. Salim, who fine-tuned my knowledge in serology and skills in serology. Mr. S.A. Olomu, my co-laborer when I was doing my project. I thank you very much. I must not fail to acknowledge the support of all the non-academic staff in the department, and indeed all the members of the Department of Hematology for your support and care. I remain grateful to all teachers in various sister departments. Names are listed and are projected. I thank Professor O.J. Areola, who was my MSc supervisor, and the other distinguished professors in chemical pathology department. In fact, that department became my second department. I appreciate the support of my siblings and their spouses. Names listed. I thank you all for coming and for your support. I thank all my cousins, the Ojos, the Adeyemons, the Atoyebis. All the names are listed and projected. I'm grateful to my in-laws, Reverend Israel and Mrs. Bisi Afolabi, for their profound affection and prayers always and unwavering support. I thank you, sir. I appreciate my Oritamefa church family, the pastorate, and the members. The names are projected for their prayers, love, and support at various times. I acknowledge and thank Set 1980 of Fakunle Comprehensive High School, graduating MBCHB class of 1987. My lovely neighbors at Alpha Grace Estate, Naihot Idishin, the many doctors I either supervised or mentored, names are listed and projected. My beloved students, past, present, without you, I will probably not be here today. I'm very grateful to the University of Ibadan past and present administration. My profound gratitude goes to the Vice Chancellor, Professor K.O. Adebowale, the Provost of the College of Medicine, Professor T.O. Ogundiran, Professor F.A. Fentola, Dean, Faculty of Basic Clinical Sciences, Professor Olayinka Omigodo, the immediate past Provost, College of Medicine, UI, all the Deans of Faculties, College of Medicine, University of Ibadan, management of University College Hospital under the leadership of our CMD, Professor J.C. Abiodun Otegbayo. I thank all the bodies of nurses that are fully represented here. I'm profoundly grateful to all who contributed to this writing and editing of this inaugural lecture. I thank Professor F.A. Fentola, Professor Oji Ariola, Professor Dr. Shehu Adekunle, Professor A. Okende, Dr. S.P. Ogundeji, the departmental chairman, thank you very much, Dr. Oladapo Aworanti, Dr. Chima Akunwata, and Mrs. Waliat Mustafa, who happened to be the lady behind the computer, my immediate family. I would like to express my heartfelt gratitude to my dear wife, Dr. Adenike Olaniyi, current principal and head, School of Nursing, University College Hospital. I captured her early in her training at the School of Nursing. For her honest and unwavering support, profound insight, and endless patience. You remain my guiding light and best friend throughout this journey. Let me say, like Ross Stewart, you will make me sing, my love for you is immeasurable, and my respect for you immense. We'll continue the rest at home. I want to express my sincere gratitude to our amazing children, Ibukun Oluwa Olaniyi and Iyanu Oluwa Olaniyi. We thank God for the amazing progress you are making in your chosen profession. To all the guests and well-wishers that have come from far and near and are present here today, I ask the good Lord to honor you all in all your endeavors. Thank you all for your kind attention. God bless you all.